Good morning. I am Toshvera Israilovna, and I am docent of the Department of Obstetrics and Gynecology No. 1 in Bucharest State Medical University, named after Abu Ali bin Sina. Today, we are going to discuss one of the serious topics in obstetrical section, which is called preterm labor, preterm premature rupture of membranes, and induction of labor. Before beginning our lecture, we have to answer one of the questions, which is, what is actually preterm birth? And when we call term birth and postterm birth. Term birth, if the labor happens from the 37 weeks until 42 weeks. If that labor happens after 42 weeks, that's called postterm birth. And if the labor happens before 37 weeks, that's called preterm birth. Preterm is defined as babies born alive before 37 weeks of pregnancy. Pregnancy are completed. There are subcategories of preterm birth based on gestational period. Actually, we divide in two forms of the preterm birth. First, this is the early preterm birth. If that birth happens from the 22 weeks until 34 weeks. And the next one, this is the late preterm birth. If the late preterm birth happens until from the 34 weeks until 37 weeks. Why we choose 34 weeks for early preterm birth? It's actually due to fetal lung system cannot synthesize enough surfactant before 34 weeks, and that can lead respiratory distress syndromes of the fetus, or today we call this diagnosis non-reassuring fetus status. Induction of caesarean birth should not be planned before 39 completed weeks unless medically indicated. Premature birth is a birth that occurs during pregnancy from 22 to 36 completed weeks. The incidence of preterm birth ranges from 5 to 12%. Among those who died in the perinatal period, the proportion of premature babies ranges from 40 to 60%. So, what kind of etiological factors can cause preterm birth? We can divide in that's medical factors and obstetrical factors. Premature termination of pregnancy caused by maternal factors. That's the maybe isthmic cervical insufficiency, malformation of the uterus, extragenital disease of the mother. What kind of extragenital disease? This is the maybe heart disease, kidney disease, or there is the maybe diabetes. And the next, this is the genital tract infection. Premature termination of pregnancy caused by a combination of factors, or we call this obstetrical factors. That's the maybe preeclampsia. Preeclampsia, this is the hypertension during the pregnancy, which happens after 20 weeks of the pregnancy. And the next, this is the PPROM, which this is the abbreviation, which means preterm premature rupture of membranes. I will explain this a bit later now. And rhesus conflict, or we call Rh incompatibility. In this case, this mother's antibodies in her blood system can destroy blood, or that's child's blood cells. And the next one, this is the abnormalities of placental attachment. For this, we have to know, in the normal pregnancy, where should placenta attach? In the normal case, placenta should attach 7 centimeters up to from internal os of the cervix on the anterior or posterior wall of the uterus. But abnormality, placenta may be attached in the cervix. That's the maybe total or partial placenta previa, or low-lying placenta. The next one, this is the premature abruption of a normal or low-lying placenta. What does it mean, abruption of the normal placenta? Abruption of placenta, one of the serious problems in obstetrician, which can increase the rate of the maternal and child's mortality. And the next one, this is the overstretching of the uterus. So, hydramnios and multiple pregnancy, that's the maybe twins or triplets, that cause of overstretching of the uterus. In these pictures is depicted preeclampsia and placental abruption. As you see, there is the placenta. Placenta is characterized by 3 symptoms. That's the hypertension. The next one, this is the proteinuria, and third one, swelling or edema. And this is placental abruption. As you see in these pictures, this placenta situated or attached in the normal place, in its normal place. As you see, in one part of this placenta is detached from the wall of the uterus, and that's caused bleeding before third stage of the labor. So, by clinical periods, preterm birth can maybe divide into 3 stages. The first stage, that's called threatening premature birth, and the next one, beginning premature labor, and premature labor has begun. And the first stage, that's called threatening premature birth, is characterized by pain in the lower back and the lower abdomen. The excitability and tone of the uterus are increased, which can be confirmed by instrumental studies. During vaginal examination, the cervix has not changed. The external os of the uterus was closed. Leakage of amniotic fluid and increased motor activity of the fetus are often observed. And the second stage, it's called beginning of the preterm birth. When premature labor begins, there is usually severe cramping pain in the lower abdomen or regular contraction. During vaginal examination, changes are noted in the cervix. There is happens ripening of the cervix. In this case, we can feel shortening of the cervix and beginning dilatation of the cervix. And maybe there is premature rupture of amniotic membrane. And the third stage, that's the onset of the premature labor, is characterized by presence of regular labor and the dynamic of cervical dilatation. There is maybe dilatation of the cervix up to 2 or 4 centimeters, that's meaning active phase of the first stage of the labor, and which indicates the irreversibility of the process that has begun. A child born prematurely has signs of immaturity. What kind of signs we can see that baby is premature? First, there is the baby weight less than 2.5 kg, height less than 45 centimeters, thick lanugo, insufficient development of the subcutaneous fat layer, soft cartilage of the nose and auricles. Nails do not extend beyond fingertips. The umbilical ring is located closer to the bone. In boys, the testicles are not descended into the scrotum. In girls, the labia minora are not covered by the labia majora. The degree of maturity is assessed using a special scale, and the condition is assessed using the Silverman scale. What kind of diagnostic methods we can use? First of all, find out the possible cause of the threat or occurrence of premature birth. For this, we have to establish the gestational period. So how can we know her gestational period? For this, we have to ask that pregnant woman her last menstrual day. If she can't remember, then we can look up her first ultrasonography, or we can measure fundal height of the uterus. The next one, this is the estimated fetal weight. How can we calculate estimated fetal weight? For this, we have to measure fundal height of the uterus and multiple, that's abdominal circumferences. And the next, position and present part of the fetus. How can we know that's baby's position and presence? By the external examination by Leopold-Levitsky methods. Or this is called palpation methods. By this, we can know position of the fetus and present part. Present part may be baby's capitis or maybe breech presentation. And nature of fetal heartbeat. How can we know fetal heartbeat? By stethoscope or ultrasonography. So, nature of vaginal discharge, condition of the cervix and amniotic sac, that's we can now by this ultrasonography or per vaginal examination. Presence of signs of infection, presence of labor and its severity. Establish the stage of development of premature birth and determine the tactics of labor management in each specific case. So in these pictures, as you see, there is the measurement of the fundal height of the uterus. So by these, we can now gestational period of the pregnant woman, that should be coincidence with the gestational period and that's the height, fundal height of the uterus. Or by this, we can calculate estimated weight of the fetus. And there is the chordotocography. By these methods, we can now fetal heartbeat of the fetus. That should be in the normal case. There should be normal range from the 100 until 180 beats per minute. The management of preterm birth depends on stages of premature birth, gestational period, conditions of the amniotic sac, conditions of the mother, degree of the cervical dilatation, presence of signs of infection, the presence of labor, the presence of bleeding. Up to 40% of preterm birth begin with premature rupture of amniotic fluid, anomalies of labor, the occurrence of fetal asphyxia, bleeding in the last and early postpartum period, infectious complications during childbirth are common. Treatment of preterm labor. How can we treat, in this case, preterm labor? We have to divide into groups. For early preterm birth, we have to use corticosteroids and tocolytic therapy. Corticosteroids and tocolytic therapy are carried out at 24 until 34 weeks of pregnancy. As I mentioned you before, which until 34 weeks, that fetus lung cannot synthesize enough surfactant, and it can lead respiratory distress syndrome of the fetus. To prevent this, we have to do corticosteroids. So, for lung maturity of the fetus, dexamethasone 6 mg every 12 hours for a total of 24 mg intramuscular to accelerate fetal lung function. Or betamethasone 12 mg every 24 hours for a total of 24 mg intramuscular. For tocolytic therapy, we can use nifedipine. That can stop contraction of the uterus. Nifedipine is given for the purpose of tocolytic therapy. For this, we have to give 10 mg per os. If that cannot help, then we have to repeat that treatment. So 10 mg every 30 minutes, then 10 mg every 8 hours as directed for 48 hours. The maximum daily dose of nifedipine is 160 mg. Contraindication to tocolytic therapy. So, first of all, this is the non-reassuring fetal status. How can we know there is the non-reassuring fetal status? For this, we have to check heartbeat of the fetus. If the fetus heartbeat less than 100 or more than 180, then we have to put diagnosis with non-reassuring fetal status. And the next one, this is the death of the fetus. Anomalies in the fetus, severe fetal hypertrophy, severe preeclampsia or eclampsia. As you know, there is the eclampsia characterized with convulsion during the pregnancy. And severity of additional disease in the mother. That's the maybe severe diabetes, the compensation stage of heart and kidney disease. Placental abruption, placenta previa with bleeding. If infection is added, that's called chorioamnionitis. Chorioamnionitis, it's the inflammation of amniotic and chorion membranes during the pregnancy. According to the time of rupture of amniotic fluid, we can divide into groups. The first group, that's called PPROM, or this is the abbreviation, as I mentioned to you before, that's the meaning, preterm premature rupture of membranes. In this case, amniotic membrane rupture before 37 weeks of pregnancy, and there is without the onset of labor pains. If we put the second group, that's called PROM, or preterm rupture of membranes. Preterm rupture of membranes. In preterm rupture of membranes, if there is the outflow of amniotic fluid before 37 weeks, and there is no any pain or without the onset of labor, any contraction. Criteria for predicting preterm rupture of membranes. So, what kind of methods we can use, whether there is the PROM or not. To check this, we have to check cervix of the uterus by speculum. Serial per speculum examination determines leakage amniotic fluid from the cervix. And next one, this is the fetal fibronectin in cervicovaginal secretion. We have to check fetal fibronectin. Fetal fibronectin, that's the glycoprotein, like a glue, which is situated between the decidua and amniotic membrane. If we find out in the smear of the vaginal smear fetal fibronectin more than 50 mg, then we can think about rupture of membranes. The next one, this is the cervical length measurement by transvaginal ultrasonography. If there is the length of the cervix less than 25 mm at 24 weeks, that's meaning that preterm birth maybe will happen. And test for alkaline nature of secretion. As we know, in that amniotic fluid there is the alkaline pH, but the vaginal discharge there is the acidic pH. If we find out there is the alkaline nature, then we can think about there is the amniotic fluid. And the next one, ferning pattern on the glass slide under the microscope. We have to take smear from the vagina and look on the microscope. If we see ferning pattern, then we think about that's amniotic fluid. And amniosure, that's a test for to finding placental alpha macroglobulin 1. In order to find out the infection has been added, there is the look for foul smelling, uterus tender, increased pulse rate of mother and as well as that baby's fetus, and regular CBC. Check for leukocytosis every 24 hours. And we have to check SRP protein. There is the amount of this SR protein more than 5 mg per liter. And to check fetoplacental system, we have to do ultrasonography. Clinical management of PPROM. So, in preterm rupture of membranes, if there are no other obstetrics complication, we have to do conservative waiting techniques, or we call this expectant methods, is carried out. So, during this expectant methods, we can use medical treatment, which we have to begin antibiotic therapy. But when antibiotic therapy for PROM have to begin after 18 hours. If labor doesn't begin within 18 hours, after leaking amniotic fluid, we should begin antibiotic therapy. If expected latency more than 24 hours to terminate of pregnancy, we should begin induction of the labor. Induction of the labor, that's the artificial contract of the uterus and ripening the cervix. In PPROM, or there is the outflow of the amniotic fluid before 37 weeks. In this case, we have to begin antibiotic therapy immediately. For this, we can use erythromycin, 250 mg every 6 hours or 500 mg every 8 hours. Induction and augmentation of labor. So, pre-induction of labor implies the artificial initiation of uterine contraction and in a quiescent uterus by any methods like medical, surgical, or combined prior to their spontaneous onset beyond the period of fetal viability. And augmentation, if there is them, plus cervix is opened, but construction of the uterus very poor. In this case, we have to artificially stimulate this construction of the uterus. For this, we have to use augmentation of the labor. Augmentation refers to stimulation of spontaneous construction that are considered inadequate because of failed cervical dilatation and fetal descent. Evaluation before induction of labor for mothers confirm indication for induction, review contraindication to labor and or vaginal delivery, performed clinical pelvimetry to assess a pelvic shape and adequate of bony pelvis, assess cervical condition, by Bishop score, and review risk, benefits, and alternative of induction of labor with patient. For fetal, we have to confirm gestational age, assess need to document fetal lung mature status, estimate fetal weight, and determine fetal presentation and lie, and confirm fetal well-being. Indication for induction, this is the hypertensive disorders of pregnancy, that's preeclampsia and eclampsia, and chronic hypertension, diabetes, renal disease, chronic pulmonary disease, premature rupture of membranes, chorioamnionitis, fetal growth restriction, RH immunization, post-date pregnancy, fetal demise, fetal malformation, incompatible with life. Contraindication to labor induction, that's the placenta previa, malpresentation, which is breech presentation, disproportion of fetal head and mother's pelvis, history of cesarean section, that's maybe corporal cesarean section, invasive tumor of the cervix, umbilical cord prolapse, contracted pelvis, and non-reassuring fetal status. That's called fetal distress. That was our last slide, and I hope that all this information will be beneficial for your studying. Thank you for your attention.